Good afternoon and welcome to the RSM's 15th episode of our COVID-19 webinar series. My name is Dr. Sarah Ann Filson and I am an infectious diseases registrar currently working at Norfolk Park Hospital. I am also a trustee of the Royal Society of Medicine and I believe I'm an advocate for increased social mobility. So today we are going to discuss a topic that has in the past few weeks been more widely highlighted within the mainstream media as more evidence has become available. And this is the fact that Black, Asian and ethnic minority people have been disproportionately affected by COVID-19. Understandably, this has caused concern within BAME communities and has led for an urgent call for investigation and action. I am joined today by two prominent guests who will give a greater insight into what we already know and hopefully how we can go forward from here. So my first guest is Dame Donna Kinnair, who is the Chief Exec and General Secretary of the Royal College of Nursing. For those of you who have in the past visited the Royal Society of Medicine, you may be aware that actually the Royal College of Medicine is right next door to us. So we are quite happy today to be welcoming our neighbour. Donna has had a number of senior healthcare roles throughout her career, but is also somebody who's been quite vocal on this matter, and I'm very happy that she could join us today. My second guest is Professor Kevin Fenton, who is the Regional Director of Public Health England of London and also the Regional Director of Public Health for NHS London. He has also had a number of senior roles within public health within the UK and has also worked at the US CDC. He was also recently named as the person who will lead the government review into how ethnicity and gender affects health outcomes from COVID-19. So I thought what I would do is I would start off by asking specifically what we already know. So what does the evidence already say about why these communities are being greatly affected by COVID-19? Kevin, would you like to start off, please?
Sure. Thank you, Sarah, and good afternoon, everyone. So the data are in fact emerging. And over the course of the epidemic, both here in the United Kingdom, as well as a number of other Western industrialized countries, it was becoming increasingly clear that COVID was not randomly distributed, but in fact, we began to see its impact, especially on socially and economically disadvantaged communities in many countries. So that link to social and economic deprivation has been a very strong one for COVID transmission and diagnosis and death. But more recently in the United Kingdom, as the epidemic evolved, we began to see first images on TV of just the number of Black, Asian and minority ethnic members of the public, as well as healthcare workers, which were negatively impacted by the epidemic. And very, very quickly, we began hearing from different research studies about how ethnic groups, various ethnic groups, may be disproportionately affected, whether in the likelihood of testing for COVID, the likelihood of being diagnosed with COVID, severe disease with COVID, and of course, the mortality from the disease. We now have a number of studies which have gone into a little bit more detail, and certainly the Public Health England review, which I am overseeing, is going to be looking at a very large cohort of patients who've been tested, diagnosed, and who died with COVID to understand these variations across racial and ethnic groups. So it's an emerging field. There are clear signals that there are differences across racial and ethnic groups, both with diagnosis and severity of disease, but indeed more work needs to be done to understand the real reasons why these are occurring and what more we should be doing to end this.
Thank you, Kevin. And Donna, would you like to add anything?
So what I was saying is that although originally we saw visually on television, that we understand that this virus has a socio-economic and structural factor, but actually what we saw in terms of, say, the first 10 doctors that we saw is we wouldn't expect them to be in the socio-economic class that normally this disease would affect, and equally for some of those nurses. So I guess to us there is an issue about whether it's exposure, whether it's biology, and I know that the Goldacre paper really demonstrated that it only partially is attributed to pre-existing conditions. And we also know, and I think it's taken as read, that there are significant factors in terms of the inequalities in health.
Thank you. Thank you both for that. So actually, I wanted to see kind of what the feedback has been from the frontline in regards to this. I personally obviously have my own insight into this working on the frontline at Norfolk Park, but I know that Donna, you also have had some experience of frontline, but apart from that, aside from that, you've also had quite a lot of feedback from our nursing colleagues to your college. So I'd really be interested to see what it is that people are saying, of feeding back to you, and what your college are doing about this.
Well, I guess initially our members reported feeling unsafe in the workplace, and that was predominantly to do with what was visually in front of them, but also a perception that there was a lack of PPE. So if I give you an example of somebody I work very closely with, this was a nurse that was actually seeing undifferentiated patients for a mental health hospital. Everybody else had been closed down, working from home behind the scenes. And she was terrified. So she rang me or emailed me, and we got into a conversation about what is she wearing. Well, of course, nothing. Well, we weren't doing that for GPs on the front line, but this was an undifferentiated group of patients. Everybody else was doing their assessments by telephone. So she felt really unsupported. And every single time she went to her management structure, they were telling her PHE guidance is that you don't need anything. And obviously that led me to fight with PHE to get the guidance upgraded, so that actually if you were dealing with COVID patients, or except for the aerogenerated procedure, that you had a measure of protection in line with the WHO guidance. So I think, ultimately I said to her, well, I think they need you more than you need them at this time. So, you might want to think about where your feet are walking. But I think that there was a lack of responsibility in the management structure, and they were bullying, and I think it was inadvertently a level of discrimination, because actually people don't feel able to speak up, and we have a culture in the NHS where people aren't speaking up. So we're unclear why these issues are there around safety at work, especially for BAME members, because there's been a slowness to answer. And I think their lived experience is telling us that they are at increased risk, but government and organisations have been really slow to respond.
Okay, thank you for that. We were actually going to come a bit later on to talk a little bit about racism and discrimination in regards to inequalities of health, and also progression in work, etc. But I wondered if we could talk a little bit now actually about first about whether or not actually, by talking about Black, Asian and ethnic minorities as one group, we're really seeing the whole picture, or whether we need to actually disaggregate them as a group and look at different ethnic groups. Specifically, I mean, I this morning actually saw an article specifically about Filipino nurses, and most of us will know that there's a high percentage of Filipino nurses who've died from this. And I think the Ben Goldacre paper also looked at the idea and showed the fact that actually people of Black African, Pakistani and Bengali origin were at higher risk than other groups. And there are some issues with the term Black African, which we won't go into on this webinar, but I wondered if you had any feeling about this, Kevin.
So absolutely, wherever possible, we should be speaking about the communities using the languages and the terms which are most appropriate to that community. The term BAME is used often in a shorthand way, but certainly from an analytic perspective, we are looking at a variety of ethnic groups and subgroups where the data allow. Been able to enable us to have much greater insights into the effects of COVID at various stages in the clinical pathway. Also, as part of the work that we're doing in Public Health England, as part of this review, we're also engaging with communities and stakeholders across the country and across all of the devolved nations to really understand what's happening, what are some of the lived experiences, and what actions are already being taken or being planned in response to this. And in those conversations, we're able to get beyond the sort of high-level aggregation of BAME into the role of faith, the role of culture, particular behaviors, risks, structural issues such as racism and discrimination, stigma and fear, and how this plays out in different communities and different community groups across the country. So in summary, yes, we have to get beyond BAME, and whether we're doing it epidemiologically or in our work in really engaging communities, this is critical.
Excellent. Okay, so moving on a bit, because obviously the majority of our audience today are healthcare professionals, and there have been a number of questions specifically about the high rates of deaths amongst BAME healthcare professionals. We know that a number of different colleges and trusts have now come out with some information in regards to risk assessing and ensuring that these people are better protected at work. And you mentioned, Donna, already about the use of universal PPE when dealing with all patients within all settings, which I think has been widely welcomed by most people. I wondered if you could talk a little bit more about kind of what you think needs to be done going forward and how the risk assessments will work.
Well, I think what we do know is the risk of COVID-19 is not shared equally across groups, but actually for those in employment, we've always had a duty to risk assess staff. And if the NHS were a factory, it would be an onerous duty if there was something that was affecting their staff members. So I think it's not, we have to do something outside normal circumstances. And I think that we need to seek the health information beyond functional capabilities. We do need proper health assessments because we know that there are some underlying conditions that exacerbate this virus. So it shouldn't necessarily be assumed that staff with identified vulnerabilities cannot work, but actually we do need to risk assess them properly and make sure that we know about any underlying conditions. And it may be about working in areas with the highest risk or highest concentration of COVID-19 patients, such as ICU. Now, clearly, it's difficult to have research that confirms this categorically, but we do need appropriate PPE. For the one thing we do know is that we're not seeing deaths where people are appropriately in PPE clothing. So I think there is something about both aspects of the workforce, the individual, the workplace, where you're working, the environment, and the individual, and making sure, as you would do for any other exposure or in a factory, have conversations between staff and managers which take account of staff concerns and preferences, and also allow them to make some level of redeployment where necessary. Now, all of us know that you can't redeploy every BAME individual from the front line. So there needs to be a proper conversation, and I would just argue the point that not every BAME is going to come out in a risk assessment as being of the highest risk factors until further information comes to light.
Thank you. Kevin, did you have anything to add on that?
So I agree with what Donna has said. It really is important that we understand not only risk assessment, but the context within which those risk assessments are going to be employed. And it really is important that by doing these risk assessments, we are not doing it in a way that is pejorative or can negatively impact staff or the relationships between staff and management. And there's something for me about ensuring that because there are multiple domains which cause increased risk of disease severity with COVID, whether it's age or gender, whether you're obese, we know that has a poor outcome, certainly smoking and having multiple long-term conditions. There's something for me about ensuring that we are consistent with how we apply risk assessments across all staff, and consistent with how we engage and support them to take full advantage of the equipment and the protection that they need. So it's really important to think about the local context and how we create better workplace environments that enable these risk assessments to be successful. I should also say that one of the things we know from the ONS data is that your risk of acquiring COVID is directly proportional to occupational risk, is directly proportional to two key factors. So the first, your probability of having social contact. So if you're in a job where you're coming into contact with lots of members of the public quite frequently, then you're much more likely to come in contact with the virus. And that may well explain some of the increased risks that transportation workers and other key workers, security guards, have experienced with COVID. And the second occupational risk is the likelihood of coming into contact with somebody who's COVID infected. And that would really explain the healthcare worker risk as well. So understanding those two things are really important as we move into the next phase of the epidemic and we begin to think about who needs to be protected and at what level, because it may well be that that will challenge us to do even more in this next phase.
Thank you. I think a good take home from that for all of us is the fact that actually there needs to be better risk assessment for all people. So not just, I mean, we're primarily talking about healthcare workers, but we do need to think about those other people who are at higher risk. So the ONS data did very much highlight the fact that there are people within other areas who have a higher risk of being infected with COVID and worse outcomes. So I think that's quite an important thing, and something that perhaps healthcare can help other industries with, given that there's obviously quite a big history of health and risk assessment within our jobs. And so I think that's something that should be taken forward. So one of the questions that came up a lot prior to us going live was in regards to vitamin D. It is the buzzword that everybody's been talking about. Many people have jumped on the bandwagon of it. I wondered if, we know that the data around it is a bit lacking at the moment, let's be honest. But I wondered if both of you had particular views on it. I mean, I personally take vitamin D because I think it's helpful regardless. But I would be interested to know what both of you think about this.
So I'm happy to start. Clearly, this is an issue where we have been very much interested in Public Health England, and the data on vitamin D and in terms of vitamin D deficiency and recommendations for vitamin D supplementation in the UK is produced by the Scientific Committee, Advisory Committee on Nutrition, SACN. At the moment, we know that many people living in the UK will have low levels of vitamin D, for which vitamin D will be, supplementation will be helpful. We also know that vitamin D is seen as a potential option for strengthening the immune system and protection against respiratory diseases. But as you rightly say, there have been no direct studies which have said, actually, if you take vitamin D, do you have a less severe course, or if you're not deficient, what your outcomes are. So this may well be an area for future research. Nevertheless, the guidelines remain the same, that for everyone in the United Kingdom, because of the exposure to sunlight and because of, especially for people of color, that we should be considering taking supplementation. But I don't, one of the challenges that we have, Sarah, is that we often look for the magic bullet. Yeah. And my fear is by focusing on vitamin D, we're taking our eye off some of the other major drivers of this risk, which may well include the deprivation, it may well include multiple long-term conditions, obesity, diabetes, kidney disease, and it may well include, for occupational risk, access to appropriate PPE. So rather than look for that magic bullet, I think we need to think of the complexity of the situation and ensure that we're looking at all of these different issues and how they interact.
I guess the only thing that I would add to that is that it does put us down a biology route, vitamin D, and we don't know the answer to the definitive question, although there is, as Kevin pointed out, guidance that says we should be supplementing anyway. So I guess for me, there's a question to be answered, but it won't be answered until we've got the scientific research.
Excellent. So we've talked a lot about kind of some of the socioeconomic factors and comorbidity factors that we think are at play here. Many people have asked the question, is there a genetic component? And one of the questions that's come up today specifically is to do with the genetic expression of ACE2 receptors and the renin-angiotensin system in regards to different ethnicities. I mean, I'm going to be honest, I don't know very much about this. I don't know if either of you two have read anything about this or have any views on this.
I'm going to let Kevin go, but I do know that some of those things are genetic factors that may or may not be different. But again, I would think that we'd have to have the research to make sure that what we're saying is not supposition or assumption, and is not let's look down a biological route and forget all the other issues such as exposures and inequalities of health. So for me, I think that it is a consideration. It's a bit like the vitamin D conversation we just had, but it needs the proof.
Yeah, so I agree with Donna on this. I think there are signals about the hyperinflammatory response that is seen with COVID and how that can influence the severity of disease progression and then leading to death. And we know that there may well be an interaction with cardiometabolic diseases. So if you have uncontrolled hypertension, heart disease, etc., overweight and obese, type 2 diabetes, these may well influence or intersect with your inflammatory response, leading to a more poorer outcome. So I think what we have to understand here is that there's a pathway. Right? So there's a pathway that goes from your social risks, the community risks, straight through to occupational, and then through to your individual characteristics and how that interplays with both becoming infected and how you manage, your body manages the infection. And all of these things, I think, will need to be considered as we move forward. The only other thing to say with the biomedical approach is that if there's signals that suggest that poor control of your weight, or poor control of diabetes, hypertension, and other metabolic conditions can lead to a worse outcome, then that gives us a signal on what we can actually do to intervene. Yeah. Because it does mean that our primary care efforts to ensure our patients who are on registers are better managed, that we're doing far more primary prevention and secondary prevention with people with these conditions to say, here are things you need to be doing to protect yourselves, then that would be incredibly useful as well.
Okay, excellent. Now, another question that's come up here, and I haven't personally read this article, so I can't really comment on it, but there was an article in the Times today regarding a study from Edinburgh/Liverpool saying that black people are not at risk. The question actually says, I feel that these studies should be properly assessed by PhD and the NHS prior to being heavily published. I don't know whether or not either of you have read the paper, and also what you might think about that, because that obviously is very counter to what we're talking about today.
Well, I guess I would say in the first instance that it might suit people to have that conversation and to put that out there. It's a bit like the inappropriateness sometimes of using just law to combat racism and discrimination at work. I think personally, there is evidence emerging that and visually and observationally, and I think if I followed Florence Nightingale, I'd react to what I see in front of me. So when we see things, the observation is also a science. So I think for me, it suits us sometimes to try and dismiss it in the first instance, and in the same way that we would dismiss the inequalities of health until they're proven.
Yeah, and this is a big issue that we have in medicine and with publications, in that many publications in high-profile journals will want to have some publicity around it. And what you miss is your ability to systematically look at a range of studies which are coming out, and then to interpret the findings together rather than every Monday or Wednesday with a news cycle. And so I think the Times paper, the paper that you've mentioned, is interesting. It is another signal, but really the test is, do we do additional studies with much larger samples to get more robust data? And then how do we collate and systematically review all of the evidence as it is emerging. And this is exactly what we're doing in PHE. So in addition to our review on the factors which influence outcomes for Black, Asian and minority ethnic groups with COVID, we're also doing a rapid review because the science is changing and evolving rapidly. So we're wanting to ensure that not only are we publishing our review, but we're looking at what else is happening in the field. What are the other studies that are being done that can complement our work as well?
Thank you both. So earlier on this week, we had a webinar which focused on kind of comparing the UK to other European countries. Obviously, with this conversation, many people have asked about the comparisons to countries in Africa, the Caribbean and Asia, given that obviously we're saying within Western society, so the US and the UK, Black, Asian and ethnic minority people are at higher risk. But if you look at the death rates in, say, I'm going to say Ghana, they're much lower than you would expect given their health system. And so do either of you two have any thing you'd like to say about that?
Well, I'll probably jump in as an epidemiologist. I think one of the things we have to be really careful about is just doing broad comparisons between different countries. You know, countries have different age structures, different demographic profiles, different social and economic profiles. Certainly for COVID, in terms of behaviors that may transmit the virus, are going to be very different in different settings. So I'd be really cautious at this stage just to do those broad brush comparisons. Now, can we learn from other countries? Absolutely. And at the appropriate time, when we're able to do the research studies that will give us all that contextual information, that will be the time for us to begin to do cross-country comparisons or comparisons across different regions. But I'd really encourage people not to jump to conclusions just by virtue of trying to compare apples and oranges at this stage. This is a relatively new disease. It is evolving very rapidly. Different epidemics are in different phases in different countries. You may end up completely comparing two different epidemics with different populations and trying to extract a finding, which would be unfortunate.
Thank you. And Donna, do you have anything to add to that?
I guess the only thing I would add to it is we know it's a rapidly evolving virus, and it's you know, its impact on UK and USA seems to be very different. And I guess for me, in the back of my head is, okay, so we've really learned, and WHO guidance came into position quite rapidly based on some of the things that we saw from predominantly homogenous populations in South Korea and other areas. And I guess for me, the important factor would be to continually update the evidence base so that we can do the right things as this virus progresses through different demographics. Okay,
excellent. So we are closely coming to an end, and I hope I can get this question in before we end, and it's specifically to do with race and racism. So the question from the audience is, why has racism been excluded from the scope of the inquiry, given the evidence of biological weathering? Racism has a physiological impact and should be considered a public health issue. And my question to you guys before all of this and before we came online was specifically, is it about time that we had an honest conversation about race within this country in regards to the effects it has on health inequalities?
I guess for me, the measures, as I've said earlier, that determine racism and discrimination at work tend to be skewed as they focus on obvious breaches of law and conduct. So if you take the example that I gave about this mental health nurse earlier, there's not an obvious breach of law, but there is some questionable conduct in terms of sticking to something when somebody's and not engaging in a conversation. And I think that we already have the cumulative impact of racism every day, but we don't measure incivility or poorer treatment or poorer outcomes because they're usually individual experiences. But we have the RES data, and it is a powerful tool. So it is essential that actually every leader, every level knows that we need to have inclusive leadership to make sure that our places of work in health and social care are fit for a workforce that is diverse.
Great, thank you. And I agree with everything Donna has said. Just to clarify, the PHE review, the epidemiological review, is looking at health service data, surveillance data on COVID. And so the information that we would want epidemiologically to study this issue is not available in those routine statistics. However, the engagement exercise that we have been undertaking, and by the end of this week, we will have engaged over 1,000 individuals getting their opinions on the issues driving this disproportionality. The issues of racism, fair, trust, discrimination, and stigma are certainly coming out loud and clear from so many of our stakeholders and partners. So we know that this is a live issue. We know this is a real issue. As Donna has said, the key issue for us is this isn't new. It's about what we continue to do about it and how do we continue to ensure that real change at all levels of our society is experienced and takes place.
Thank you. I think that's a really great note to end on. And I really want to thank both my guests today for giving us such an insightful discussion. I think they've really given us some food for thought. I apologise that we couldn't get to more questions, and this is something that obviously we could talk about for hours on end. So what I want to do is thank you all for attending today, and want to just give a plug to our ongoing webinars. So our next webinar is on Tuesday and is on mental health. It will be with Professor Tim Kendall, who's the National Clinical Director for Mental Health at NHS England, and also Professor Ed Bullmore, who's the head of the Department of Psychiatry at the University of Cambridge. So once again, I'd like to thank you all for joining us, and I'd like to bid you adieu for the day.
Thank you.
Thank you.